Actually, fantastic job. I mean, I think you very methodically kind of went through that and set that up each step of the way to kind of have one lead into the other to ultimately have kind of those overall studies and showing that adjustment to a RAF score and how that can be achieved. And I think, a lot of common themes kind of have come in with these virtual events. And I think one of those, and I know, we kind of got into this a little bit yesterday, but, how do you feel like you can utilize certain scenarios to engage CDI within a quality approach or within those discussions? Do you see that more around a specific diagnosis from time to time, or just around a common theme, or kind of what's some tips as far as getting CDI involved in that quality approach and some practices that you have at your location?
Yeah. So for me personally, coming into quality, of course, I had knew nothing about these registries and all the abstraction work that goes on, and then just how important the documentation is to those as well. They're not claims based, but they do rely on claims for validation. So what has really popped up here recently is AMI, and I know that is not new, but really, really making sure that we are clarifying type 1 versus type 2. So for the NCDR, chest pain MI, CAS PCI registries that we participate in for our accreditations and such, type 2 MIs are excluded from those. Type 2 MIs are also excluded from the inpatient AMI readmission and mortality measures. So not only does the documentation have to be clear from an abstraction standpoint, it really needs to be clear for a coding standpoint on the type of AMI that we're treating. Another I don't want to say challenge that we have faced is the definition of an AMI. At my facility specifically, our cardiologists aren't always the ones that are admitting and are the attending on the patient, depending on the type of AMI they have. So if it's a STEMI and they come in and they have a PCI procedure done, then yeah, your cardiologist is going to be the attending. But if it's an NSTEMI, sometimes our hospitalists are the attending on that case. So trying to tie the documentation into the quality of care is, I'm lucky enough here in Paducah to have a STEMI coordinator, a nurse on the inpatient side. That's all she does is works with AMI patients. And she has started following these patients on the inpatient side, making sure that we are doing our standards of care related to the registry and discharging our patients on the right medications, getting them into cardiac rehab, and really following through and making sure that we're doing everything that we're supposed to do from a quality of care standpoint. But she has faced some of the same issues. And she's like, Ashley, I really feel like a lot of these are type 2 MIs based on the fourth universal definition of an AMI. What this has done is this has led us to start having conversations at the system level about what are we defining for our system as an AMI? What is going to be the expectation for our providers in the documentation of an AMI? We have worked, now that I'm not in the CDI world, I still work very closely with our CDI manager and our coding manager. And CDI and I went to the CV service line and was like, we need help with this. Not only does it impact coding and impacts abstraction for our registries and the stuff that our physicians are really, they're more focused more likely on the NCDR registries than they are the claims-based stuff. So if we can speak their language a little bit and say, this is why we need this corrected, or this is why we need this a little bit more specified, we're going to get a little bit more buy-in. So that's one of the things that we're working on now, and then trying to think of ways that we can utilize our EMR to make it easier for our providers to document such a way. Once we get a standardized definition decided upon, the next step is going to be boots on the ground education. And that will not be a CDI only project. It really needs to be a little bit of everybody. Everybody needs to start talking that language of, hey, we really need to specify this a little bit further than just saying NSTEMI or what.
Yeah, no, absolutely. And I think that, that kind of, again, ties into some of our earlier events, with utilizing your STEMI coordinator as far as, the approach from a quality perspective, I feel, has a lot of those commonalities, meaning what are the resources that I can utilize now? How can I utilize some of the technology to my advantage? and then ultimately getting those key stakeholders involved, and more importantly, kind of driving that conversation through, clarifications on specific diagnoses or just areas that are hot topics, to where pulling in, the CDI team to have a quality understanding to the approach on those items as well, and you being able to continue that dialogue between other internal resources that may not be in the CDI department, but ultimately kind of link in with each other through that, as far as really driving a lot of the extension of communication, to the providers as well. And I know, we kind of got into this a little bit yesterday too, much on that AMI focus that you have, just that the pneumonia and sepsis linkage kind of we were talking about, and principal diagnosis, secondary diagnosis, and then ultimately kind of when to apply kind of that risk adjustment. Can you just kind of walk through that, for the audience as far as your approach on those?
Yeah. So like I said, if please get on qualitynet.org and really start studying these quality measures. It is really important to know the specifications and how they actually work. So for pneumonia mortality, it's really interesting. So for that particular measure, pneumonia can either be primary or principal or secondary. And if it's a secondary diagnosis, then the principal must be sepsis. So just imagine how many sepsis patients with a secondary diagnosis of pneumonia are coming into your facilities and are going to be potentially falling into that cohort. That's going to be a lot of patients. At least I feel like that is for us. What's interesting, if you read on a little bit further in that specification, if there is a secondary diagnosis of severe sepsis coded on the claim, the patient's excluded. So it's really, really important to educate your providers on why they need to document that AKI is related to sepsis, that respiratory failure is related to sepsis, because we know we have to have that documentation of the relationship between sepsis and the organ failure to be able to pick up that code. That's going to make it stronger from a denial standpoint, and also is going to support that code so we can exclude those patients from those value-based purchasing measures. To me, I feel like that's probably an easy education point and an easy query to ask. If you do see those patients that have sepsis as principal, pneumonia as secondary, and they were both POA, we need to see if there's organ failure related, if it's related to sepsis, and get that coded so we can get that patient out of that cohort.
Yeah, absolutely. And I'll tell you what, definitely utilizing those opportunities within the inpatient setting. And I thought you brought up a good point about that yesterday, right? There is no better time than ultimately, during that inpatient stay to really turn around and figure out, that HCC capture and kind of risk adjustment, right? Don't take that opportunity for granted and utilize that to your advantage.
Absolutely, because there's so many acute diagnoses that are really only captured in the inpatient stay. And you have to know what type of providers impact a RAF score. So an RD diagnosis of malnutrition isn't going to be captured on the ambulatory side as an HCC because it's not the right provider type. But if you can get that on the hospital claim, we can get an HCC out of that, and it turns it from a nutritional diagnosis to a medical one. And then we also have to think about from a community, a population health standpoint, where are our patients receiving their primary care services? If you've ever worked in a facility long enough from one place, you have your frequent flyers that come into your facilities. And a lot of those patients are utilizing our ER and our hospital as their primary care. So there's an opportunity on those particular patients that we have to seize the day and get those HCCs captured on those patients for sure. Because there really is no... I just spelled my name wrong on here. I spelled it wrong. Sorry about that.
No, that's all right. We needed to have a quality review of the presentation, right? Make sure it was, your last name was in there correctly. But, but no, I think honestly to that topic too, I think that, being able to bring in, CDI, during those areas where they can kind of apply that pressure, if you will, or that, clarification. I know we were discussing this yesterday, but you kind of touched on the presentation, but just, if the hospitalist is the attending and the cardiologist has their consult, but there's more there from a cardiologist perspective, but then you're only getting it from the hospitalist side, right? Like, how do you utilize that consult and apply CDI to your advantage to ultimately then get that clarification on the consult to now get the hospitalist and the cardiologist kind of seeing the same thing and speaking the same language, right?
Yeah. That's our ultimate goal with our initiative right now and trying to get AMI clarified. And then CDI, that's where you guys come in. If there's, conflicting documentation between the heart specialist and the attending that's a hospitalist, let's clarify that with the attending. The cardiologist saying this is a STEMI due to spontaneous coronary artery dissection. We need to clarify that or code it as such, as that spontaneous coronary artery dissection as principle, because that's actually a type 2 STEMI. We have found opportunities of like that, reviewing our work and our data. But yeah, TBI plays a big role in that, clarifying between specialties when they're not speaking the same language.
So, just as kind of a final thought process, right? And I know you touched on, some pretty low-hanging fruit, if you will, as far as areas of opportunity for education, and then, utilizing, CDI, and then, your internal resources such as your STEMI coordinator, which I think is, super cool in the way that you're utilizing that skill set. But, for anybody out there that, would like to start to nibble, let's say, from a risk adjustment standpoint and quality and kind of ingraining that within, their either established CDI, department or one that they're looking to kind of have a little bit more of a 360 vantage point, if you will, what are kind of some of those crumbs or some areas that individuals can easily implement or one most likely are going to be able to get the value out of that risk adjustment, if you will, and see those small wins kind of stack up?
I think malnutrition is big. That's a really high coefficient that's going to make a big impact. Specifying your CKG or your CKD, and then diabetes with complications. Some of those can be linked without queries per the coding guidelines, and there's probably some big opportunities on your coding practices just to make sure you're utilizing that. I would say those are probably some of our lowest hanging fruit, and then just making sure that we're picking up if a patient has cancer, metastatic cancer. That's a really big risk adjuster, and sometimes that gets missed a lot. Especially like if the patient's on, I forget what the name of it is, but that long-term chemo drug for breast cancer, if they're taking that, we need to make sure that we're capturing that breast cancer and it's being treated.
Yeah, so those larger areas of opportunity, right, within malnutrition, and those other diagnoses that you had mentioned, those conversations are already happening within the facilities, right? I mean, you're already kind of, it's a tug of war already on a lot of those. And now being able to utilize, let's say, that stage to start to maybe deviate a little bit or start the quality risk adjustment process, because there's already a lot of chatter around those diagnoses anyway, right? So you can use that area from an education standpoint and kind of filter in the quality aspect, start to pull in some of the risk adjustment, because those conversations are happening already.
Yeah, and then, and then start tracking, when your facility gets your hospital specific report, don't just let it sit there. It probably goes to your quality department, reach out to your quality director, and just ask them, hey, either can you help me understand this, and start keeping a track of what your percentage of your patient cohorts are risk adjusted. And then you can start to track that year over year. I just got my latest hospital specific report for value-based purchasing, and from our initiatives from this study to what I just got, we did see some increases in some of our condition categories and capturing those risk adjusters. And our biggest one was malnutrition. I think I saw a 5% increase on our capture rates.
Wow.
So you can, it takes time. This isn't an easy, or I won't say easy, but it's not a quick turnaround on results. It takes time and patience to see the results of this and to tie it in for sometimes your leaders, your hospital leaders, to see the impact and the relevance. But it's worth it. It's worth the time to take for it, to keep it in the back of your mind, and to always keep talking about it. Even when people tell you not to talk about it, keep talking about it.
Stay consistent, right? Absolutely,
Yep.
for sure. Well, again, very, very much appreciate your time. Great presentation, and thank you all, for attending the event.